Okay. There we go. Okay, how's that working for everybody?
It works for me.
Perfect. Just to say, obviously, I can't see a chat window or anything while this is going on. So, Andre or Caroline, if anything kind of comes up that needs clarification while I'm talking, just shout at me and I'll stop and we can talk through it.
We'll do, and we'll keep an eye for the questions at the end.
Lovely, thank you. So yes, so I'm Emma Pearce. I'm a medic by background, and I'm currently an ST4 registrar in public health. And I've been working with the West Midlands Violence Reduction Unit since September of last year. So when we're talking about the West Midlands, we're talking about our seven local authority areas that are also covered by West Midlands Police. So Birmingham, Coventry, Solihull, Sandwell, Walsall, Dudley, Wolverhampton. There are also two other violence reduction units, one that covers Nottinghamshire and one that covers Leicester, Leicestershire and Rutland. And the violence reduction units, as Andre said, are partnership organisations essentially set up mainly between police, public health, local authorities, and then bring in lots of other different partners, so health, voluntary sector organisations, the criminal justice system, youth offending teams, all of those sorts of people to really come together around this issue of violence reduction and try and implement some change. And it's sort of, they appeared really on the back of a lot of work that had been done in America and then had been brought forward. And actually, a lot of the initial work in the UK was done in Glasgow and then across Scotland. And so we're really building on the learning from there. Violence reduction units are funded by the Home Office. It's all a bit kind of ad hoc, as with many other funding things. I'm sure you're all finding this in medicine as well. So we get yearly funding. We're actually putting together our funding application for next year's funding at the moment. Bear in mind that next year, when we talk about financial years, actually started 3 weeks ago. So as you can see, the process is a little bit behind itself, but we are getting there. In the West Midlands, our funding pot is around about 3.4 million for all the work for the year, with a few extras here and there. Nottinghamshire and then Leicestershire and Rutland get a lot less than that. Obviously, they're smaller areas and there's a bit, I was going to say less violence. There's different types of violence that they have to tackle, and they are just generally smaller areas, so they get a bit less funding. So I suppose the first thing to say is why should people in A&E actually care about this as a problem? Why are we interested in reducing violence and violent crime? And I've got a couple of kind of screenshots here from the PHE fingertips tool. I don't know if any of you are familiar with that, but it's my absolute go-to for a data dashboard. Anything that you think you might want to know about your local area in terms of data, looking at the wider determinants of health, sexual health, child health, pretty much anything, the data is probably there on fingertips. And what we can see for the West Midlands region is that violent crime really is kind of concentrated in some of these particular hotspot areas, Birmingham, Coventry, Sandwell, Wolverhampton, and they're the ones that are covered by our violence reduction unit. But what we've also got are problems around domestic abuse related incidents and crimes, and they kind of fluctuate depending on areas that you're looking at. And something there called the crime deprivation score, which is a little bit out of date, but is quite a useful indicator to kind of show us areas where things are happening on the ground that might make crime and violence more likely. And basically, the higher that crime deprivation score, the worse off that area is in terms of risk of crime and risk of violence. So as you can see, those big inner city areas, Birmingham, Coventry, Stoke-on-Trent in particular really flags on this one. They're at really, really high risk of crime, and a lot of that is driven by deprivation, lack of jobs and work, poor educational attainment, those sorts of things. In the East Midlands, that picture is really quite similar as well. So it's those inner city areas. It's Nottingham that's really, really flagging for violent crime on here. I seem to remember when I was at medical school, I lived with somebody who grew up in Nottingham, and she was not a great fan of the fact that Nottingham always used to come up, I think, as the knife crime capital of the UK at that time, about 11 or 12 years ago. There are also some indicators there that sort of Derby and Leicester in particular are not doing brilliantly in terms of hospital admissions for violent crime there. And again, that crime deprivation score, as you can see, Leicester and Nottingham flag even higher than Stoke-on-Trent did on that crime deprivation score. And what I really wanted to kind of highlight to you is that things are getting worse. Oh, is somebody off mute? So things are definitely getting worse. And it's not just the impacts of COVID as well. As I think many of you will have seen, COVID has changed the way that violence presents, and it's changed the way that people, interact with each other across society. But even before the impact of COVID, things were getting worse, and particularly so for young people around their experience of violence. So one of the things that we know that really, really drives a young person's involvement in violence is being permanently excluded from school. And those children are at hugely increased risk of them becoming marginalised from society and engaging in violence and violent acts and violent crime. And those school exclusions are on the rise. For us, Wolverhampton is a really big flag area. So Wolverhampton has some of the highest rates of school exclusion across the whole country. And we don't quite understand why that is, but we can see the effects in terms of the crime patterns there. We also know that referrals for being involved in gangs are rising, and they're rising out of proportion to what we think we might see if it was just that reporting was becoming more common. So it seems as though people are finding it easier to report, but there are also just more young people being involved in gangs and gang culture. We've also seen that hospital admissions for under 18s for assault with a sharp object are rising as well. Trauma teams in particular are seeing really high rates of knife injuries in over 16s. I'm sure those of you that sort of work in major trauma centres or have worked in major trauma centres in the past, this isn't going to be news to you. QE in Birmingham undertook a study that was published last year, it's referenced on the slide there, but they found that it was about 13% of the workload for their trauma team just dealing with people who'd had knife injuries. And then if we look away from knife injuries, assault with a sharp object, that sort of thing, and we look at domestic abuse, we also know that around 5 to 6% of all adults aged 16 to 74 have experienced domestic abuse in the previous year. And that's from the most recent crime survey for England and Wales. I think that was completed March 2020. So there'll be another one coming soon. And that'll be really interesting to see, because anecdotally, there have been changes in the way that domestic abuse is happening and the way that domestic abuse presents, but that hasn't quite tallied up with some of the rapid research that's been done over the year. So it'll be interesting to see what's going on there. But certainly those numbers are going up. So really, I'm here today to kind of talk to you about what can be done, both from our perspective, so public health professionals and others working in the violence reduction units, but from those of you that are working on the ground and seeing people on a daily basis who are the victims of or the perpetrators of, and slap my wrist because I don't like using that language, people who are involved in violence. And what I've got here on the screen is from the WHO prevention work, looking at how do we prevent violence. And it gives us this idea of a cycle of actions that we undertake to try and understand a problem, look at the causes, tackle those causes, and then keep cycling this around to ensure that we improve things. So if we start with that lime green section in the top left-hand corner, so we need to start really with surveillance and horizon scanning. So surveillance is understanding what does the problem look like now. So it's all about data. It's all about understanding what's coming in the door, what's going out the door, what it looks like when it gets there, who are the people that are involved, you know, as much understanding and kind of baseline data as you can get. And then horizon scanning is using that data to find trends and then extrapolating those trends out and saying, over the last 10 years, maybe we've seen a change in X, we've seen a change in Y. I therefore predict that that's going to carry on over the next 10 years, or I predict that that might reduce slightly over the next 10 years, but some of that burden will be transferred onto something else. So we want to understand what's happening now, but we need to kind of look to the future at the same time and make sure that what we're doing is future-proofed in however we can make that happen. Then if we move to that red quadrant, we then start to look for risk and protective factors for violence, and we'll talk about those a little bit later on. But if we've got all of our baseline data, we need to then sort of start pulling it apart and saying, hang on a minute, we're seeing an absolute abundance of people between the ages of 16 and 18. We're seeing huge numbers of people who have never finished mainstream schooling. We're seeing huge numbers of people who come from families where, you know, the last 2 or 3 generations of parents haven't had long-term employment. So we're looking for risk factors, but then we're also looking for things that are protective. So is it that we're not seeing many children from divorced families or multi-generational families, or, you know, whatever it is that you can use that data to tell you about what perpetuates the violence and what protects people from the violence. That orange quadrant is talking about developing and evaluating interventions, and those interventions need to speak to the risk and the protective factors that you've identified, and also that horizon scanning that's been undertaken. And then the blue quadrant is talking about, once you've developed and evaluated those interventions, how do you pick out which ones worked and upscale that, both into effective programs, but also effective policy that covers your organisation, that covers the region, and then we just keep going round and round. So in A&E, when we're talking about surveillance, the things that you know, public health professionals and violence reduction unit colleagues would be really, really pleased if these were kind of on your mind, is something around information sharing to tackle violence. So for those of you that are aware about ISTV data, I know it's a real pet project of Caroline's, and she's working really closely with the violence reduction unit to try and find ways to improve the collection of this data. But essentially it's 4 key questions about people who arrive in A&E and they are the victim of violence. They've been subject to some sort of violent attack. And what we're interested in is the time and date of the incident, the time and date of the arrival into A&E. So we're looking at that kind of time lag, the specific location of the incident, and the primary means of assault. So is this an assault by weapon? Is this an assault by fist? Is this an assault by vehicle? You know, those sorts of things. And for many years now across the West Midlands patch, we've had the West Midlands Injury Surveillance System, which has asked units to collect this data separately to all the other bits and pieces of data that you collect on all of the patients that come through your doors, and submit that into PHE on a monthly basis to try and do some of that surveillance and build in some of that horizon scanning and really work out what's been going on. And the principles of this are based upon the Cardiff model. And what the Cardiff model really showed was that if you could do things...
I'm good now, ma'am. Let me
Oh,
bring my
is somebody off mute? Thank you. So the Cardiff model really showed us that if you can pinpoint things such as the timing of the incident and the specific location of the incident and the primary means of assault particularly, we can then feed that information back to our local authority colleagues, particularly in licensing departments, in their community safety partnerships, and they can take concrete actions. So they can apply to have more police officers on the streets around particular pubs that we know are problematic. They can apply to have off licenses or other different types of licensed premises shut down if that's what we think that it might take to curb the incidences of violence in that area. But we can't do that, and we can't ask our colleagues to do that unless we've got that data that shows us what's going on there. We are looking potentially at whether this information can be collected through ECDS, although that would mean foregoing the specific location data. But what that would add is that we'd get demographic data, and we could do a little bit more of that looking at risk and protective factors. So it's a bit of a balance. But what I'd really like you to take away from this particular bit about surveillance is just that data really is important. And it's important to us in public health, it's important to the local authorities, but it's important to your patients because, you know, we're asking for its collection in order to improve outcomes for the patients and in order to stop them coming back through your doors time and time and time again. So when we're looking at risk and protective factors, what my boss at the VRU says all the time is the risk factors for crime are the risk factors for inequality, and inequalities and kind of where they arise and how they affect health, you know, that's not new for any of you. But it's, I think, you know, one of my take-home messages for today really is that the risk factors for crime are the risk factors for inequality. So if you know that you're working in an area with specific inequalities, keep that in the back of your mind and see what's going on locally or in your hospital that you can get involved with and really try and kind of get behind and support to reduce those inequalities, because you will be having a knock-on effect on the crime and the levels of violence in that area. And obviously this links in really with work around the NHS long-term plan, the white paper that's come out fairly recently that will likely start to change the way things work from next year. And the other thing I've just popped on here as well is that nobody expects you to notice most of them, and we definitely don't expect anybody to be able to fix any of these risk and protective factors in emergency care. It's been a long time since I've worked in A&E, I'll give you that, but I do remember the speed at which things had to happen when I was working there before. And, you know, that speed isn't conducive to picking out any of these things and really delving deeply into the causes of what's going on. But actually, if you don't ask, if you don't give people that tiny little bit of space to say, what's going on? You know, how are you today? What's, you know, what do you really think has brought you here? You're not going to find anything at all. And if you do find something and you write it down in the notes, then actually we in public health are working really hard behind the scenes to find ways to draw out as much of that data that you're collecting as we possibly can and do with it what we do best, which is, you know, working out exactly what's going on and then designing programs and projects to try and fix that. So yeah, I think it's just really about understanding that nobody expects you to fix any of these things, but we'd love you to ask, and that's really it. I've just popped this graphic in around risk and protective factors. The writing on it is quite small, but it's really just about thinking about how to break these things down into risk factors that affect the individual. So you've got your genes, your perinatal aspects of development, bits around nutrition, behavioural and learning difficulties, all of those sorts of things. School readiness, that's a real one to kind of keep your mind on. So if any of you are working in peds A&Es and you get those young children that are coming in and you just think, there's just something not right here with this 3-year-old, with this 4-year-old, they're just not quite where they need to be, you know, it's often likely that they're also going to be the ones that struggle really with school readiness, which then often then translates later on into those children that end up being excluded. There are also risk and protective factors around family relationships, so whether there's domestic abuse within that family, which is a really, really big risk factor for young people being involved in violence and being exploited. And then there are community and societal risk factors as well, but certainly the ones that are going to be most apparent and most obvious for you guys working in health are going to be the individual and the relationship ones. The community and societal ones, that's very much can be left to us to sort out. And just a few specifics here around county lines as well. I'm sure most of you are seeing this much more frequently and are kind of well aware of the issues around county lines. But just a few kind of pointers here that I'll leave. I'll share the slides when we're done, so you can have a look at this if it's interesting or useful to you to have those things in the back of your mind that are very specific to county lines and county lines exploitation. That third bit of the cycle was around sort of piloting and evaluating programs, and this is a list of some of the different things that that can go on in emergency departments to really kind of look at addressing youth violence in particular, but also other types of violence. So some of you will have worked in areas where there are St Giles or Red Thread specialised youth violence prevention workers. So I know we've got St Giles embedded in Wolverhampton and Coventry, and we've got Red Thread workers in QE, in the Children's Hospital, and normally in Heartlands. But since Heartlands has been very COVID focused, I think we've withdrawn our Red Thread worker just for the moment. Other areas are looking at getting more generic local authority youth workers embedded into their hospitals. And the idea behind these workers, for those of you that have never experienced this type of work before, these people are there. If you see a young person who's been a victim of violence and you think, gosh, this person really needs somebody to talk to, they need a bit of extra support, maybe they're looking a bit unkempt, maybe they've disclosed to you that actually the family is really struggling with housing, maybe you've started to go through different forms and assessments with them, and you think, hang on a minute, their literacy isn't where I would expect it to be. They've come in with really extreme mental health issues, or maybe not quite so extreme mental health issues, but you can see that those issues are related to why they've been a victim of violence. Those workers are there for you to go and have a chat with and say, this person needs something extra. This person needs a bit more support. And they're there to be the link between the hospital and the outside world and kind of give that young person a bit of ongoing support after discharge. And what's been found, particularly with St Giles workers in London in Bart, is that they can change the atmosphere of the emergency department. They can really kind of quite quickly form good relationships with those young people. And they stop those young people coming back in the same state on future occasions. So really, really kind of say, if you've got youth workers in your A&Es, work with them, talk to them, learn from them, refer anybody and everybody, because the worst that they'll say is, no, we're oversubscribed. If they say, no, we're oversubscribed, they'll come back to us and tell us, because in the violence reduction units, we tend to be the ones that are funding them at the moment. And we might be able to find more funding. So, we'd rather you use the service and then it needs more than not use the service and then we have to withdraw it because it's not a good use of money. Other similar things that are ongoing in other areas around youth social prescribing projects. So, this is social prescribing, but just specific youth projects. There are violence prevention nurses, there are clinical champions. So the roles of these people are more around doing what I'm doing now, but in the workplace. So really kind of, getting that word out there around violence prevention and what can be done and why it's important. And then other things that we can fund within the violence reduction units and could be funded directly by the hospitals as well, linked to work around domestic abuse. So certainly Birmingham Children's Hospital has what we call an independent domestic violence advisor. who is there to work with families who come in and disclose issues around domestic abuse, and that IDVA is there as an independent advocate for that person, a real kind of supportive space, who again, like the youth workers, will continue to talk to them outside and continue to provide them with that support. And then that last bit, the sharing, learning and upscaling good practice, there's a little bit in here for those of you on the call who are still training. There are a million miserable aspects about being a trainee. I understand all of them. However, when looking at preventative programs and a public health approach to looking at violence reduction, which is what this is, make the most of being a trainee, because it means that you can buddy up with other trainees, and every time you rotate around, each of you can sow a few more seeds. You can pull on the good and bad practice from other places that you've seen, and you can start to talk to people every time you move and say, oh, well, the Children's Hospital had one of those youth workers. Why couldn't we have one of those youth workers? Do you know who you need to talk to? And then also there's something there around buddying up with people who you know are staying. So, talk to the consultants, talk to those associate specialists in the staff grades, talk to the nurses and say, you're going to be here long after I've gone. If we start this project together, are you happy to continue it? And the other thing, just while I'm here, is those of you that are working in hospitals that are covered by a violence reduction unit, we want to work with you. We really, really want to work really closely with the teams to try and understand what else we can support you with. Can we help you with the data collection? Can we help you with teaching or training? Can we help you with supporting of projects and programs? Can we help you write funding bids? We've got all of that expertise sitting in the violence reduction unit, so we are there to help. Just one last little bit as well is that it is not all about the patients. So we also know that staff can be really badly affected by violence in the workplace as well. So, we're talking about overt violence, patients against staff, but we're also talking about bullying, undermining, social media use. And there is the new NHS standard that's just come out that's trying to look at how we tackle some of this. And as I've put there, we can look at things like bystander training, anti-bullying training, embedding a zero tolerance policy for bullying within your workplace, and also again considering the effects of domestic abuse on staff. So I know in the Children's Hospital, again referring back to their IDVA, their domestic abuse support person, I know that their IDVA is also there to support staff should staff need it. So it's really just kind of making sure that I've asked a lot of you all. I've kind of thrown a lot of information at you all, but it's not all about the patients. If there is support and if there's support that staff need in order for staff to feel safe and to not be victims of violence in their own workplaces or in their own homes, then again, the violence reduction units and your workplaces in general are there to support that. So I'll stop there, see if there are any questions. My contact details are on the slide, but as I say, I'll send those through to Caroline and hopefully she can share them around the network. And as I said at the beginning, there are 3 local VRUs, which are the big Home Office government funded networks. But ask around, because actually there are lots of smaller networks linked to local authorities that are working, doing some of the same things, but just with a much smaller budget. But they can always call on us and see how we can work together in partnership.
Lovely. Thank you, Emma. That was a very useful talk. And I'll be honest, I think I need to learn more myself about this. Any questions in the chat? I haven't seen any, but I've got a couple of them myself. Do you know if there's a plan, or is there is a national network that covers violence reduction? Would you be able to tell us more about that?
So I can tell you a tiny little bit. So I know within NHS England, Martin Griffiths has taken up the post of National Director for Violence Reduction, or some other similar title. And so for those of you that don't know, Martin is a trauma consultant at Barts. And Barts in London is one of those centres that's really been the driving force behind a lot of this work in recent years. So there is a network within NHS England. I'm not actually sure, I'll be honest, whether there's anything clinical nationally beyond that. I know there's a VRU network, and there's lots of things around where the public health professionals and the policing colleagues come together to meet. But yeah, certainly clinically, I'm not sure, but I can go away and ask.
Very interesting. There's a question from Tina. How do trusts submit ISPTP data? Or how do you see that?
So it's an interesting one. So Tina, are you from the Children's?
Yeah.
Yes. So across the West Midlands, historically, the Children's Hospital has not been part of the injury surveillance system that we've had running. So we've never actually really asked you to submit ISTV data before. But we think that that's going to change. I know we've been having some discussions with Katie Wright around how we integrate the Children's into that system a little bit more. Historically, it has been a separate data collection. So it's been working with your IT teams and reception teams mostly, gathering data on a monthly basis and then emailing that through to PHE. But we are meeting this week and we might be changing our ask, and we might be pulling data from ECDS internally within PHE. And so actually there won't be an ask as such on trusts to submit the ISTV data to anybody in particular, although noting that ISTV and engagement with this kind of information sharing to tackle violence is a mandated NHS standard.
Caroline, do you want to put that question out loud instead of me reading it? Because I think that's a very interesting one. I love it.
Yeah, so Emma, I think everyone who's listened to your talk agrees that this is really important. We don't do enough work on prevention in emergency medicine, to be honest, and it's something we need to do more on. But most of us don't know where to start. So I was just wondering if the violence reduction units could think about providing ideas for quality improvement projects for EDs, so that you could give ideas of audits that we can carry out and strategies that we can try ourselves, because it's almost like you don't know what you don't know. I think lots of people would like to give them some ideas, obviously not compulsory, but if we do want to think about how we can improve what we're doing in ED, where do we start? Have you got any ideas now of projects that you guys have been thinking about in your unit?
So nothing that kind of specifically comes to mind, but I really like that idea actually. I'm sort of, my brain's drifting back to when I did obs and gynae before I came into public health. And as an obs and gynae trainee, I was presented with the Royal College kind of audit list of these are the things that we need to be clear about, and these are the things that we need to understand better, and pick one and do your quip for the year. And so yeah, actually we could totally get together as a set of violence reduction units and say, this is what we think health colleagues might be interested in, this is where they could help, this is where they could support. And yeah, and then we can come up with some meaningful, useful quip projects rather than some of the kind of quick and easy wins that often trainees get left with doing. I will take that away and have a real think about it. Yeah.
Another question was that, half of our hospitals on this call are from Northamptonshire. So is it true then that we don't have a big violence reduction unit?
Not as far as I'm aware, no, but it's one of those things that there will be something happening within the local authority. So each local authority should have a violence reduction strategy. It's whether that particular local authority or local authorities that cover the area then have the capacity, the money, the time, the headspace to do anything about it. But that's not to say that those of you that are working in the Northamptonshire hospitals can't go and talk to the Nottinghamshire VRU or the LLR VRU and say, we'd like a bit of help and support to try and implement something here. Is there a contact in one of the other hospitals that you can put us in touch with, or,
I think also, Emma, if you can help find us who the contacts might be for that, that would be really helpful.
Yeah.
We can share that with our colleagues as well within the trauma network. Thank you.
Absolutely.
I think actually for me this has kind of been an eye-opener, because over the last few years across Northamptonshire we've seen a significant increase in crime, in most importantly in gun crime and gangs across some of the areas. I've actually seen more gun crime in the last 2 years that I've seen in the last 10. So we know something is happening. So I think this is going to be, we need to look further into it. So really appreciate that. And there's one more thing, there's one more takeaway message. Sorry, Sarah, I'll give yours in a second. For me, at least, I always looked at ECDS, at the coding bit, as a bit of nuisance, asking for lots of information that goes into a nowhere. I think we need to look at it from a different point of view, because that data is it's potentially crucial to actually know where to focus the resources in the community in working on that crime prevention. So yeah, thank you for that, Sarah.
Okay, so thank you, Anna. So just thinking more from a regional point of view, as you know, this is Central England, but we also work with the Birmingham Black Country and the North Staff Stoke area as well. You know, and talking about the contacts and thinking more like about what Caroline's point is, you know, we don't know what we don't know. And back in February, just before the pandemic hit, we had an injury prevention day, which Tina and Caroline attended, and violence reduction came up as one of the items on the list. And I know Chris Moran, from a national point of view, wanted trauma networks to get involved in the violence reduction units, because I had emails, and that was sort of 2 years ago, and then it sort of dropped off, and I never got invited to any sort of discussions or study days. So I think from a regional point of view, what I would like, if you can help, is to, as you said, try and find contacts that us in the network can sort of, I suppose, introduce ourselves to, and see what we can pull together as a region, and obviously, you know, not just Central England. The other question I was going to ask is, how accessible is the data that you've got from that fingertips tool? Because we have an amazing data analyst, and again, also worked in A&E pediatrics, so clinically really knowledgeable, does a lot of work with TARN. And again, at our injury prevention day, we were talking about, you know, what are the priorities? So when we're talking about, you know, the quips and things, what are the priorities? And I'm just thinking, if we could get hold of some of that data,
yes,
and I think Steve's maybe on, is to try and figure out from for our region, and also then individually for each network region, what those priorities are. That might go towards some better discussions about the future of this kind of work stream.
So on the question around kind of networking and linking people together, I can absolutely help and support you with that. I'm very happy to take that away as an action.
Thank you.
And kind of pull something together. On the data, so fingertips, you get what you see on those screenshots there. So the data behind that dashboard is not accessible to anybody that doesn't work for PHE.
Right.
And I think, and I don't know what others think, but I think personally that this is probably one of the issues, is that you have excellent analysts in the hospitals, but they can only touch your data, can't they? They can't pull in data from other hospitals or from the local authority. And within our violence reduction unit, we have a team of analysts, and they can look at the data from across those 7 local authorities, but they can't access the hospital data individually. So I think there's a lot of work to be done, because I agree, if you could really get the people on the ground to be able to access data from across different areas and not just their narrow little slice.
Absolutely.
It would really help and improve things. But yeah, certainly the stuff behind fingertips, not so accessible, I'm afraid.
Okay, well, you know what? Just because it isn't right now doesn't mean it can't be. So if we can get to the right people to ask for that data and kind of show them what networks can do and how we can work with each other, because you know, just one organisation can't do this on its own. I mean, I'm from one of those red areas, so you know, I do see what's going on, and I think. And I know of organisations within my area that do this, but they're probably not joined up. That is the art. That's what networks do. So if we can start having those conversations with the right people, then hopefully, you know, another year down the line, we might be in a different place.
Sounds great. Yeah, well, I'm pleased that people are so enthusiastic about this. Yeah, really, really pleased.
Thanks, Emma.
Lovely, Emma. Thank you ever so much.
Thanks all. I'll leave you to it.
There's lots of messages for all of us to take home from this one. We've got next Dr. James Harding, consultant interventionist at UCHW, who's going to talk to us about the interventional radiology in trauma. Hello, James.
Hello, can you hear me okay?
Yes, we can hear you.
Fantastic, thank you. Can you see my slides?
Not yet, I can't. I can see you.
Okay, I just need to share screen then, hang on.